Good afternoon, Pratap. Sorry for the slight delay. This is Dr. Srinivas Kumar
Good
here.
afternoon. Good afternoon. Good afternoon.
Yeah, we can see
I
and
can hear your sound. Can you hear me?
yeah,
you hear?
we can see you and hear you very well. With me, Dr. Mirasolo Farang from Germany, Dr. Surya Prakash, Dr. Kaparthi,
And
and Dr.
Surya
Anand
Prakash
Khan.
Rao, Anand Gantraj. Four
Anand
people.
and
I was
Kaparthi.
hearing the talk and all.
All top CTO people
Yeah,
are
yeah.
together. And with this, I request
But
you
actually, I want.
to. Sorry.
Yeah. So Srinivas,
Please
thank you
cut
once
off the
again
Zoom
for
link,
allowing me to join for the TCT India.
No, in spite of all odds, you came here on first day,
First of
then
all, I
again
want.
giving live case again. Hearty thanks to you, and you are the 25th live case operator, Silver Jubilee, I would say. In this meeting, all cases went well. Over to you, Pratap. Over to you, please. We kept it purposefully in the end
See,
so that
thank you, Srinivas.
crowd will remain for you. You kept purposefully your case in the last. Thank you.
But thank you, Srinivas. Thank you, Srinivas. Actually, I just wanted to tell you, since this case is sponsored by Abbott, I was thinking that I will do a OCT guided bifurcation stenting, not CTO. It is not a CTO. So first of all, I will tell you it is not a CTO case because actually I'm not doing OCT for a long time. So since the OCT, all the CTO operator, let them see how I am doing a LMCA bifurcation. So I will show the angiogram. Please, can you just go ahead?
Your patient is a 55-year-old female.
Can you show this?
Just show that. Just show that presentation. Just show presentation. Just show the presentation slides.
Correct.
Yeah,
Go ahead,
patient
go
is a
ahead.
55-year-old female.
please
She had
go
an
ahead,
angiogram 1
with-
month back. At that time, the angio showed LMCA plus 3 vessel disease. The culprit vessel was RCA, and patient underwent PCA to primary PCA to distal RCA. And after 3 weeks, patient came here for now LMCA bifurcation PCA. The angiogram shows distal LMCA that's a true bifurcation lesion. Distal LMCA 70%, osteal LAD 70
Next,
to
next,
80,
next,
and
next.
circumflex osteal also osteoproximal tubular 80% disease.
Next.
So the plan
Showing
is
only this.
distal LMCA
Hey, can
bifurcation.
you just tell them to show this? Slide. Slide change already.
Just show the angio.
The slide change already. They can come to here. They can come to here, live.
You can show the angio.
Angio, yeah.
This is
So
the
we-
angiogram.
Can you show today's angiogram? Actually, Surya Prakash, we did an angioplasty to the RCA earlier. Just can you show the RCA last shot? No. This is actually done earlier. It was the RCA stenting done. Next. This is the angiogram. It's LMCA bifurcation with a lesion with a OM with an LAD disease. Next. Actually, today we put 2 wires, one into the circumflex, one into the LAD. Then we did an OCT. Can you show the OCT run?
Just show the OCT, LMCT, LED run.
No, first OCT run. Can you OCT can be in the main screen. OCT main screen. Okay. Can you Manu can explain the OCT?
Yeah, OCT, the morphology of plaque is basically a fibrotic plaque. That's a minimal lumen area of only 2.4 millimeters squared in distal LMCA and 1.7 millimeters squared in ostial LED. The plaque is mainly a fibrotic plaque with a spotty calcification. And the distal reference area is the LED, the proximal LED is around 3.25 EL to EL. And LMCA, the EL to EL is around 3.62 millimeter. And the
See, effectively there is a bifurcation lesion. LED. Actually, there is echoing his ear. I don't know why. LED, LMC distal part is only 2.7 millimeters square. Vessel is.
We didn't follow. It was ostial LAD or mid proximal LAD.
Yeah. Actually, that is the LMCA bifurcation area is only 2.17 and proximal LAD is also diseased. But when you go to the distal LAD, is totally diffusely diseased. So we decided to do only the LAD osteoproximal part and the LMCA distal. Now we did an OCT to the circumflex also. Can you show the next? In the ostial circumflex to LMCA OCT showed a significant disease in the distal circ. Can you show the distal circ? No, distal circ. Can you come back? Can you come back? Come back. That part. The area is only one. Can you show the area? A little more.
What we see is a borderline lesion, which needs
1.05.
probably, which needs
No.
maybe
Just see
FFR.
that 1.05. 1.05 is the area in the circ distal part. Say LMCA, there is a circ distal part is 1.05. If you go to the proximal part, can you just go back? Can you go to the proximal? Proximal, and little more proximal. That is actually at the ostial circumflex. Little more proximal. That part. Little 1.5 only the area. 1.5. So there is a distal part is 1.2 and proximal part is 1.5. The vessel distally is 2.5. So we decided to take the length is nearly 30 millimeters. So we have to take a 33 millimeter stent for the circumflex. And we are planning for a DK crush. Any comment now, please?
So
I am
you-
actually echoing.
Why do you
I don't know
choose
that the
DK
audio visual is
crush?
not good.
You want to do
Yeah. We
what is the strategy for the distal left main stenting? Because how much is the
distal
syntax
left.
score,
No, it will be a DK crush.
the
DK crush.
calcium, the angulation? What are the
Syntax
points
score
you
will be less
take
than 20.
for the learners? Is that the circumflex
Surya?
ostium,
So you don't
block in
believe
the ostium, size of the ostium, and the size of the LAD and
Ostium is
left
only-
main. These are the points to be taken for the stratifying two-stent
Correct,
strategy or
correct.
crossover stent or a provisional stenting.
So actually, Surya, can I just tell you?
Please.
The LAD ostium is deceased. LAD circumflex ostium is deceased. Circumflex ostium is only 2.1. LAD osteoproximal is only 2.2. Circumflex distal part is deceased 1.05. LMCA distal is also deceased. So we have to take a double. There is no doubt that because the ostium circ and ostium LAD is deceased, you have to do a double stent strategy. No doubt about it. Which stent strategy is ideal? We always prefer to do a DK crush.
And why?
And in the DK crush, we
So
have to,
you-
for the circ.
You want to prepare the
Why,
bed or
please tell. Okay,
what
please.
strategy for any debulking, anything?
Any DK crush technique, you have to do the pre-dilatation. Since there is a severe fibrotic lesion, we take a cutting balloon. We have taken a cutting balloon of 2.75 balloon. Next, can you show? This is a 2.75 cutting balloon we have taken. We dilated both the circosteum. Next. We dilated both circosteum and LAD ostium. Then, next, in the distal circumflex, we took a normal 2.5 millimeter balloon and dilated, not the cutting balloon. So our strategy is we measured the stent sizing. It will be 2.533 stent from circ. LMCA to LAD will be 3.5 stent, which is 20. Then initially we will put a stent. Then we will be crushing with a balloon. Initially with a 3 and then 3.5 balloon. Surya, you can make comments.
Can we ask you, so you predilate the distal circ, and the next step will be to put the perform focal distal circ stenting, and then try to approach the distal left main?
No, Ferengai, my plan is to put a single stent from circosteum to the distal circ, which I can cover with a 33 stent.
So you plan to take one very long stent?
One long stent, and LMCA to LAD will be one stent of 23 millimeters, which will be 3.5. Then after crossing, then recross, DK crush. After that, the final pot will be with the 4 millimeter balloon.
I think, so from my point of view, so at least in Germany, we would perform focal stenting for distal circ. That's a really very short lesion, and then try to reduce stent length, and just to focus, probably we need 24 for left main to circ. But okay, if you decided to take one very long stent, that's okay, but I think
No,
there are
20,
few
no, long stent
millimeters.
is actually, Ferenc,
Yes, Dr.
Ferenc, I
Ferenc.
wanted to understand, you take a 24, then another 10 millimeters stent means 33 millimeters. I am taking only 33 millimeter stent.
Okay. Go ahead.
2.533, please. 2.7533.
I think this will be still for left main.
Actually,
This will be still option to go by provisional approach from European point of view.
no, because actually ostial circumflex is actually only 2 millimeter. Can you just go for a provisional? What will be the opinion about other panelists and other experts?
I think
What is
culotte
this?
will be optional as a bailout culotte, and normally we would doesn't start with a dicky crush approach in this case. But interesting. So there are many ways, you know, to treat patients. So now this is 2.75 long. Which stent?
2.75, 33, so it is actually in a science expedition.
Science, okay.
Check.
Dr. Pratap, you are familiar with DK crush? Hello?
Yeah, I
Because
will be-
as per
I
EBC
will-
left main,
what-
you can do provisional stenting also equally, stepwise. But as you are familiar
No,
and
my
already
point
you
is,
opted.
my point is,
Yeah, please.
no, Kaparthi, I am asking you, with an ostial circumflex disease of 2 millimeters square in the
Yeah.
ostial circumflex,
Okay.
which is extending more than 7 millimeters, can
Okay.
you go with a provisional or not? This is my question.
No, it is a familiarity of the operator with which he is familiar. He can adopt that one. Because as we know, definitely two
actually,
stents are required. And DK crush, you opted. That's all.
No, we do a DK crush in all the cases here, and we have completed 670 left main, and we published in Indian Heart Journal, probably the largest data of the country. And this actually having a 7-year follow-up of the patients also there, which is actually showing that the data showing and nearly total 10% event rate in total 7 years.
You
You
got
can
here,
see that this the placement of the stent is like this.
you got a 7 French system.
Tell me, Surya.
You got a 7 French system.
7
here?
French system. I always go with, 7 French system. Actually, a stent is placed. Our plan is actually, you have to put a little more distally to the, we will go to another angle to see that the ostium is placed perfect or not. Just can you go to the LAO cordon?
For perfect dicky crush, you need some overlap with around 2-3 millimeters. But in this case, you have to go
We are actually keeping.
2 millimeters more distally.
No. Ferenc actually, all the science stent, the marker is actually having the stent starting. So that is why the point, we kept the marker in the LMCA only. You can see this is the placement of the stent you can see now. Actually, I kept perfectly, the marker is inside the LMCA. So
No, it
definitely
looks
it is
not bad. Right.
into the LMCA.
Go ahead.
Just go ahead with the stent.
It's only 0.5 millimeter, I think, no? Marker
Nominal. Yeah. No, actually in Surya, that is why many people prefer science as a stent for the placement of the stent will be perfect because the stent is starting from the marker. In all other stent, it is nearly 2 millimeter away. So now I dilated in the nominal pressure, but I take the same balloon back.
Sideband optimization.
Now the modification of DK crush is like this. I just take the stent balloon back and I dilate with a high pressure now.
Sideband optimization.
Go. Because I wanted to open the ostium very well. Go 15, 18. So we just dilated the ostium very well now. Now we will take the balloon out. This actually, one step actually now they added in the DK crush. But before taking the wire, I will check the distal part whether it is okay or not. If it is okay, then we will take the wire out. Can you just take the balloon out? Small check. Already wire is taken out, very good. So
What would you do now if you have now distal dissection? Because
No,
now
then
you
I'll
lose
put a
it,
wire
the
again.
wire, yeah,
No,
you
no,
know,
there is no
you
problem.
know,
I can easily
sometimes,
put a wire down.
sometimes it's not so funny because
Sometimes it
then
is difficult. Ideally, you should not.
Sometimes,
Ideally, you should not.
sometimes you keep the wire, nothing will happen. Usually, we used to think that everything to be taken
No,
out,
no.
but you can.
Crush the
No, not like that.
stent
Deliberately.
with a nominal
It
pressure.
came out.
what we see, the balloon
Yeah,
for
yeah.
crushing
It is
is
3 millimeter
much too
deflate.
small. You need definitely one more larger for crushing.
Go. We took a 3 millimeter, very balloon, very well dilated.
That in
deflate.
left man you need
Now we
probably
have to do the
4.0.
Yeah, actually we measured as
Extended crush.
3.7 by the OCT, but we have to extend the crush. So we can take a balloon now, the wire again, recross, and then go to the. We can do a pot
The
crush
next
now. We are
step
going
will
to do
be,
a pot crush now.
Doctor, next step, according to the newest approach in Dickey Crush, which is recommendation from Dr. Chen, you should perform now again a pot maneuver to achieve a better stent strut crushing. And next step, you will cross in the mid part of ostium with a wire. So now it's maybe a bit too long. This
Now
balloon
I am
is too
doing
long.
this is actually a pot crush. We are just going to keep the balloon there. It is a 3.5 millimeter balloon. It's a pot crush. Go.
Yeah, this is very
Inflate.
important.
LMCA with deflate. This is actually the latest addition by our Chen. Go.
Yes, Pratap, extended crush with pot, higher size, below.
Yeah. This is actually, initially we used the 3 millimeter, now it's a 3.5. Now we can take this balloon out and we have to take a wire down into the circumflex. Can you just give the same wire you can give me? After wire, we will do kissing inflation. We can do one more thing in this step. Now, after wire crossing, we can check the OCT and understand that the wire is gone into the right strut or not.
It will be
according
interesting, yeah.
According to the
What-
Chen, what we should do is a non-distal crossing is the ideal one.
Dr. Prathap, what is the experience in nano crush? We've done some cases and follow up. Really
I
good.
do that. Nano crush is very good, very good. Just go to the LAO caudal.
Here, angulation is good for you, whatever technique
This
you
is-
want to do.
Moreover, the wire crosses, everything is good.
So which wire do you take? Some floppy wire or
usually-
polymer wire?
This is actually a filter FC wire. I am actually a reasonable CTO operator, so I am always familiar with these type of wires. So I just take the wire.
Pratap, we got another 3 minutes. After that, we'll go to
Then
Bangalore.
you'll come back again, right?
Maybe you need to make a little bend in the tip of the wire.
Yeah.
So take time, it's sometimes very difficult.
Yeah, it went.
Crossed.
Yeah, cross, okay. Maybe let the balloon and now make OCT to show us it was a distal or proximal crossing. It will
Can
be
you just
interesting.
get the
use
OCT,
imaging,
OCT to the LED? No, OCT to LED. Will show that whether it is crossing correctly or not.
Do you have
don't want-
really good flow in LCX at the moment?
Yeah.
Good flow.
Okay.
We will actually,
You see,
it
you
is
could,
actually more of a
you could
proximal
treat
crossing.
this case very nicely with provisional approach, as I recommended initially.
Correct, but
Thank you.
epicranial. No, I will be just showing the OCT now, then you can go.
The problem
Just to
is
see the
many
crossing
people
only,
don't
just
believe in how often the single
ready.
stenting for distal left main is really suitable, you know, and This is for more than 80%
ready.
of cases you can use just one stent and final kissing.
That follow-up will be good with single
Ready.
crossover stent, whatever
Ready.
strategies. No?
പെട്ടെന്ന്
So you
പറയടി.
can always do a physiological study in the circumflex, and if it is needed, you can go for.
He makes the procedure very complex, but there are many different steps which have to be
കൂടെ നിൽക്കുന്നവരാരും
perfectly.
റെഡി റെഡി.
So now we will check the crossing.
കറക്റ്റ് കറക്റ്റ് റെഡി റെഡി. ആ can see the crossing. Manu, can you explain the crossing? Just go to the OCT.
You could probably also make 3D reconstruction, then to see from inside the crossing between.
No, he will show you a
spots.
longitudinal. See, this is the crossing. Can you see that OCT now?
Yes, we can see.
Yeah, it's almost a proximal crossing.
It's a proximal crossing, non-distal crossing. It's a proximal.
Yes, so this is the same. Yeah.
It's a
Now
proximal
clearly see
crossing,
that it's
right?
crossed through the proximal part. Yeah. Yeah, yeah.
One strut is there. Huh? Only one strut.
This only crushed part. This is a crushed part.
This is. I think you are perfect.
This is
now in
actually, now you
position.
have to do a lot of other work, you know. Yeah. Now we can actually, you can go to the place and come back. By that time, I will have other shots.
Yeah, you can go ahead.
Dr. Pratap, shall we go to Bangalore and
you'll
come
go,
back to
please.
you?
Yeah, you go and come back. Come back. Please do that. I am ready. I have done everything.
Okay, please go ahead and show what you have done after you left.
So we hope you are happy.
No. Okay. I am very happy.
How
Can you
about
just
patient?
go? This is the shot. The stent, patient is happy. I am happy. All the colleagues are happy. Ferengi is also very happy. So the stent is there. You can see the stent. Then balloon there. Next.
First part.
This is actually the first part we have done. Then after that we crossed. I think you have seen the crossing.
Yeah.
You have seen the crossing. Okay. This is the OCT. Next. Recrossing. This is actually we are trying to now the recrossing.
LMCT, let me send it down.
No. This is actually the first kissing. Next. One balloon. This is actually a 2.5 balloon only. Next. We have taken a 3 millimeter to the LAD circumflex and LAD 3.5. Next.
Okay, first
Then
kissing,
this
well
is
done.
actually stent.
And
First kissing. Then we have gone for the stenting now. This is actually a 3.5 into 23 stent. Again, science expedition. This is the pot. Next, pot is done for recrossing. Now the recrossing. This is the proximal strut. Actually, we don't want to go non-distal. The wire is crossed. After crossing,
Just show the OCT.
we have done an OCT. Can you show the OCT now?
Just show the OCT image on this.
OCT. This is the OCT run.
OCT clearly shows crossing through the mid part of the circumflex.
Some
Non-distal
mala
cell
position
cross.
there.
Yeah, that.
Can you see the crossing? Can you?
yes, we
No.
can see.
Actually, it's, Surya. This is actually we wanted to show the how the crossing is done. It's a
Exactly.
non-distal crossing, mid-cross almost.
Mid crossing, yeah.
Can you just show the image again? No, you have to show the OCT again.
This before
Just
the
rotate
second-
it, we are able to see it before.
See some steps in the osteum.
Yeah.
Yeah. Can you see? This is the. See, this is actually almost mid-cross. 1 or 2 stent strut into that one. Then you can see one strut is there, but mid-cross opening is very good. But we this is the way. Can you see that now?
Yes, perfect.
Perfect. And next, we will
To do kiss.
for the ghost. This is actually now we took a 3.3 millimeter. I don't know. I have to take the balloon.
In the final
After
kissing
stent,
stage now.
Standing. No, before that. No, no, just go.
Finished, huh?
Take the balloon out. Now we are recross the wire. This is the balloon. Next balloon. These two balloons together.
And which balloons do you use for final kissing?
3 millimeter balloon into the circumflex, 3.5 into the LAD, and we took a 4 millimeter balloon in the LMCA. Now you can see the position of the pot. So we just kept the stent mark, the balloon marker at the carinal proximal part.
Yeah, the most important
Final part.
Listen me. The most important point is to perform final kissing using NC balloons. Did you use NC balloons?
It is an NC balloon. We keep the balloon tip at exactly at the proximal part of the carina, so that again the crushed part should not create newer carina, should be avoided.
Before the neocarina.
Before the neocarina. Next. Now we are actually going to do OCT again, final OCT.
Okay.
We are going to show the final OCT.
Could you make final angio to have impression how it looks? Probably perfect.
The time of OCT only we take picture.
Before
that we give
the-
angio, because I can avoid
Yeah,
some
that is why.
You can
That is
conserve
why
the
I was
contrast.
deciding that to avoid contrast. So the OCT catheter going inside. Can you see that we just don't want beyond that, because we want the distal part is correct. Can you just show the RIO code? You come, please. One. Okay, we are beyond. We can okay. We are okay. We are making a 54 millimeter pullback. Ready? We will be seeing the distal end. That will be, it will be for the ML. It is for the max. That is a medial dissection, apposition and expansion. Ready? Are you ready? That fellow can go to the central.
By accident?
Can you just tell him to show in the middle part? OCT. OCT middle part.
Just show the distal edge. Just show the distal edge. To look for any distal dissection.
Small micro dissections
See
common
the
in
distal edge, there is no
OCT.
distal edge dissection. Yeah.
No, I don't. No, do you see? Are you seeing any dissection? I don't think. Small
micro,
dissection. Correct.
Small dissections, but it's very common
Just show the
to have an OCT.
just show the distal expansion how much? Distal expansion how much? Minimal stent area. So expansion is almost proximal expansion.
Can you show the area also?
Point of confluence.
114% is expansion.
Is excellent. Yeah. LMC expansion, just show.
LMCA,
Distal
can you
LMCA?
just show? LMCA's expansion is also very good.
Area.
No, what is the area?
Area
7.98 is a distal LMCA.
8 millimeters square. Yeah.
Proximally it will further
Proximal is 11,
11.
10.75.
Expansion almost 98%. Okay.
And can you show to the LAD ostium?
Just show the LED ostium.
Little more. We got only, this is 4.96. It was 1.9 was the area earlier. Can you show to the bifurcation
Just show the
then now?
sarcostium.
Sarcostium. Can you see the sarcostium?
3-dimensional.
Srinivas?
Yeah. You can put a 3-day bifurcation, we will see it
Sarcostia,
better.
sarcostia.
Yeah, now clear scene.
Yeah. The strut is taken off totally.
Struts are also, no struts across.
It's really nicely opened.
Very nice.
We can do one more thing. We can actually take the wire into this circumflex and do one more OCT run if you want.
No, but ostium is seen quite well. It's
Yes,
no
yes.
problem.
Yeah. That's
So-
the only thing. And
So we believe you have done a really great job with double kissing stenting. for this quite complex left main, especially circ lesion.
I'm actually sorry to Srinivas, I did not show an LM CTO.
Yeah, I was expecting that, but anyway, you did a great job in left human bifurcation and excellent result. Congratulations. A big round of applause for Pratap.
Okay.
Congrats, Dr.
Congratulations.
Pratap,
Thank
for
you,
your silver
Pratap.
jubilee
Thank you.
case, 25th.
Silver Jubilee
thank you.
case finished.
Thank
Incidentally,
Thank
it's
you,
so
this
happening, Pratap. In the opposite, your counterparts are doing exactly the opposite. Ostium midshaft, you have shown the bifurcation. So it so happened. Anyway, good result. Congratulations. Thank you again for all the cooperation and kind words towards us.
Thank you.
Okay.
Thank you.
Thank you. Bye.